Hello everybody, I'm Dr. Arshia and today let's just have a quick recap of Neet MDS 2019. So a little bit into the exam, once the students entered the examination center, they were asked to register giving their biometrics and each student was assigned a computer. So they had to wait obviously as long as the exam started, and once the exam started they had to log in with their credentials and there was an instruction format which they had to enter, which they had to read and submit and then start off with the exam. So once they started off with the exam, so if this is the computer screen, so if that's the computer screen, so the questions appeared and you had two options. One was to mark for review and the other was clear. You had a sideboard here where all the questions and their numbers appeared. Very simple to navigate between questions. There were two parts, part A and part B. And let's look in a little more clearly into part A and part B. Part A had 100 questions and part B had 140 questions. Okay. Now, part A, part B, please do not confuse it with the segregation of basic and clinical subjects. No, it was just a segregation into two parts. The questions obviously were mixed up. There were basic and clinical mixed up. There was no segregation between subjects or between the topics, whether it was basic or clinical. But in order to move into part B, a student had to actually appear and answer all part A questions, at least view the questions, if not answer the questions, and then move on to part B. So how exactly was the exam? A very mixed response. Some found it okay, some found it easy, some found it tough. So what I would like to tell you here is, considering Neet MDS 2019 paper, one thing I'm sure every student would have realized now is just pure solving of MCQ without any direction is not going to lead you anywhere, because it was very conceptual, it was very application based. So considering the image based questions, almost 1/5 of the paper, that is close to 50 questions, were image based. So now you know how the pattern has changed, or it is evolving, or it is becoming much more, conceptual, making the patient, asking the student to in fact identify what the correct answer is. So the basis of this paper is very clear, that your foundation has to be concrete. You really cannot just mug up the questions and go and appear for an exam, because now it's going to be more knowledge oriented. It's going to be very knowledge based. So today it's a quick recap of few questions that we'll be discussing regarding Neet MDS 2019. Let's keep it as conceptual. Let's make it a little more easy and let's see if we can actually learn the content better, learn the topic better. So let's look into one of the questions. Speaking about amino acids, essential and non-essential. Now, many students have gone wrong in this question. It's very simple, but you know, these are the subtle things that you need to remember on your exam day, right? It's like all your years of hard work, all your months of hard work, it is just tested on that one particular day, on the 3 hours of duration. So very easy way of remembering essential and non-essential amino acids. Firstly, what is essential? What is non-essential? Essential amino acids are something that are not synthesized in our body, that needs to be provided externally, right? And non-essential are the ones which are synthesized in our body and which are present in plant and animal forms, which can be taken in these forms. So a very easy way of remembering this, a simple mnemonic that will take you a long way. Any help in learning these little molecules proves truly valuable. amino acids, little molecules. It's just this one simple mnemonic is going to really help you. Starting with the first letter of each word, A, H, I, L, T, L, M, P, T, V. So A there stands for arginine, H stands for histidine, I stands for isoleucine, L stands for leucine, T stands for threonine, L stands for lysine, M is for methionine, P is phenylalanine, T is for tryptophan, and V is for valine. Now, in all these amino acids, except the first two, that is arginine and histidine, which are semi-essential amino acids, you can consider them as non-essential amino acids. The remaining, all of them are essential amino acids. All of this are essential amino acids. So when you're clear with what is essential amino acids, it becomes very easy to know what is non-essential amino acids, right? So if you just keep this in mind, this particular mnemonic in your mind, it's going to make things very easy and you're definitely not going to go wrong in your paper. So the next topic that we'll be discussing is Hydatid cyst. Familiar? I think you are able to recall what exactly I'm talking about. So when we speak of Hydatid cyst, Echinococcus granulosus. Okay, now that's a parasite also called as dog tapeworm, and these parasites are present in a definite host. Okay, you need to remember about the definite host. Now the definite host is a dog. Okay, so now this parasite is present in the small intestine of a definite host, where example is a dog, and when they are released, okay, these eggs are released in the feces of the animal and they can spread to a suitable host. Now, how do they spread through a suitable host? Is through three things. One is contaminated water, food, and animal fur. These are the three areas or three modes of contact, how this particular parasite, the larva, the eggs, it gets transferred from a definite host to a suitable host. A suitable host can be man, can be a sheep. So what happens here? Once the larva, the eggs, reach the suitable host, they form cysts, which are called as Hydatid cyst. What are the symptoms? There'll be nausea, there'll be stomach pain, chest pain, all of this in case of Hydatid cyst. So most important, what you need to remember here about is a definite host and a suitable host. What are the definite hosts? Example, a dog. And what are the suitable hosts? Can be a sheep, can be humans. And what is the mode of contact and spread of this particular condition? So the next thing that we'll be learning about is Romani classification. Now you need to know what exactly this classification is in order to answer the question, right? And I'm sure many of you students were really confused as to what the particular image actually spoke about, right? If you do not know all the 6 types, 6 classes of Romani classification, it's very difficult for you to even arrive at the right answer. So, Romani MA classified partially edentulous maxillectomy arches into 6 types. You need to know all the 6 types in order to identify what exactly it is, right? So, coming to class 1, now class 1 is when the defect, when the resected portion, it is along the midline of the tooth, midline of the maxillary arch, Okay. This is class 1. Going on to class 2. Class 2 is when the resected portion is unilateral, okay, and there are teeth present on the anterior teeth present on the contralateral side. That's class 2. Class 3 is when the area is involving the hard palate. It can even involve a portion of soft palate. This is class 3 classification. Coming to class 4. Class 4 is when there is a bilateral defect with just few teeth present on the line of the arch. That's the defect area. Class 5 is when the defect is posterior to the anterior teeth. And class 6 is when the defect is anterior to the abutment teeth. Now, class 6 is usually happens in congenital and traumatic cases. Now, if you look at this image, if you look at the figure, it's very clear to you what class 1, class 2, class 3, class 4, class 5, class 6 is. So, when an image is given to you and they're asking you what type of Romani classification this is, this image has to pop into your brain. So, only then it becomes very simple for you to arrive at the right answer. Hope I've made it very clear to you what this classification is all about. Next, let's look into another term, Opisthotonos. I hope most of you got this right because it's pretty simple and straightforward. What exactly is Opisthotonos? It is the hyperelasticity and spasticity of muscles where the head, the neck, and the entire spinal column is in an arched form. It's in a bridging form. So the patient actually here the muscles are affected, the axial muscles go into spasm, and most important causes, one of the causes could be because of any traumatic injury to the brain, and it can be a symptom of tetanus, right? Pretty simple, straightforward. I hope you guys got this answer correct. Let's look into another topic. Now, the question was about prodrugs. To even get into that, you need to know what prodrug is. Prodrug is something that is metabolized in the body and it's converted into its active form, right? So the main usage, why exactly a prodrug is given, is to study how the drug is absorbed, it's distributed, it is metabolized and excreted. So in a prodrug, when it is actually administered, when it's ingested, it gets metabolized into its active form. So here the bioavailability of the drug can be increased, the adverse effects can be reduced. The drug chooses when it interacts with cells and processes as to if it needs to be active there, if it's not in targeted area, and where it needs to be actually targeted and where it gets converted into its active form. So you need to know a few examples of prodrug. I'll just give you a few examples like levodopa, and the active form of it is dopamine. If it's prednisone, the active form is prednisolone. And enalapril, the active form is enalaprilat. So I hope that concept is clear again. So coming to the next topic that we'll be discussing is the most important thing, lumbar puncture. Most of you have gone wrong here because it was about the layers, the last layer that is pierced in order to draw CSF. What is the last layer? In order to even understand this, you need to know the layers. You need to know a lot about it. So let's look into this. So a German physician in the year 1891 introduced this. It's nothing but a spinal tap where the lumbar puncture is done from L3 to L4. Most commonly, sometimes it's done from L4 to L5 or L5 to S1. So L3 to L4 is the most common site where the lumbar puncture is done. You need to know the layers in order to actually get into the right answer. So coming to the layers, there is skin, there is superficial fascia, supraspinous ligament, interspinous ligament, ligamentum flavum, epidural space, dura mater, arachnoid mater. Gets a little tricky to understand. Let me make it very simple for you. Let's look into this layers. Now that's the skin and the superficial fascia, okay? And here are the ligaments. So now when a needle is injected, okay, now this is the skin. The first layer is the skin. The second layer is the superficial fascia. Now, when the needle is injected, this is the interspinous ligament. So, the first give happens when it reaches the ligament flavum. So, here is where the lumbar cistern is approached. The second give is when it enters the dura mater. So as it enters the dura mater, it pierces into the thin arachnoid membrane and lands into the subarachnoid space from where the CSF is drawn. So the last layer to pierce is the thin the arachnoid membrane. So the answer is arachnoid mater. That's the last layer to pierce in a lumbar puncture. Now, why exactly a lumbar puncture is done? For diagnostic purposes, in case you want to, if a patient is suffering from meningitis, in case of other conditions, this is for diagnostic purposes, a lumbar puncture is done. Coming to the next topic, let's discuss about the walled defect. Very simple. It's just that you need to know the image in order to answer the question, right? So I hope you know that you have to change the methodology of learning. It's just not about reading. It's about also correlating with what kind of an image it follows. So this, the pattern of reading, it has to be very image focused as well, for the fact that almost 1/5 of the paper was image based. If you're just going to read the textbook without even looking at the picture, it's not going to take you anywhere. So you have to correlate, you have to imagine, you have to look at the picture, you have to internalize those images into your brain. Only then it's going to be very simple on the day of exam when you actually have to arrive at the right answer. So coming to walled defects, you need to know what exactly is walled defects. Now, Goldman and Cohen classified angular defects based on the number of walls present. So this is a confusion among students. What is 1 wall, 2 wall, 3 wall? 3 wall defect doesn't mean it's a defect involving, all the 3 walls. 3 wall defect means there are 3 walls present. There's just 1 wall that's missing. This is where majority of the questions students go wrong in identifying what is wall defects. So when we come into 3 wall defect, let me just show it to you. Now what is this? Very clear. It's a 3-wall defect. That is, only one wall is missing. Only the mesial wall is missing. So there is distal wall that is intact, the facial wall is intact, and the lingual wall is intact. So it's a 3-wall defect. Right? Pretty simple. Coming to 2-wall defect. Now how does that look? Now that's a 2-wall defect, right? What are the 2 walls that are present here? That is the lingual wall and the distal wall are present. What is lost here? The mesial wall and the facial wall is lost. Now look at this. Now that's a 1-wall defect. So the facial wall, the lingual wall and the mesial wall is missing. So what is the only wall that's present there? It's the distal wall. Only the distal wall is present. It's a 1-wall defect. So just looking at the picture, you need to know how many walls are present. That will tell you what kind of a defect it is. It is not about how many walls are absent. It's how many walls that remain, which will tell you what wall defect this is. So let's look into the next topic. Staphny bone cyst. Now, Staphny coined the term bone cyst. This is nothing but these are lingual concavities present on the inner surface of the mandible, and they are exactly not true cysts. They are pseudocysts. Radiologically, they look like cysts, but they are pseudocysts for the whole fact that they are not lined by an epithelium. These concavities have an intact cortex over it. Okay. So, how do they exactly appear? Now, the various synonyms also you need to remember when it comes to Staphny's bone cyst. So, the various synonyms are, it is also called as lingual mandibular depression, lingual salivary gland depression, Staphny defect, and various other terms. So, the most important thing here you need to remember is its location. So, it is usually located near the inferior alveolar canal. So, that's the mandibular canal. That's where the cyst lies. Pretty simple, straightforward. It's a pseudocyst for the whole fact that it's not lined by an epithelium. It is just a lingual concavity which has an intact cortex over it. Okay. So the next thing that we'll be discussing about is first, second, third order bends. Now what exactly this is? Now coming a little bit into orthodontics, you need to remember that the appliances, the fixed appliances that were designed and programmed. So initially there were the 3 different types of appliances that were introduced. First was a completely non-programmed device, then it was a semi-programmed appliance, and then it was a fully programmed appliance which had both. Now, what exactly is the difference between all the three? A non-programmed appliance did not do any tipping, no torquing, whereas a semi-programmed appliance did only the tipping functions, had no torque, whereas a fully programmed appliance does both tipping and torquing. You need to understand what tip, what torque is to understand what kind of bends this is. Very simple. Just follow me. It gets very easy here. So coming to the first order bends. Now the first order bends are nothing but the in and out bends. Now for example, this is the tooth. Yes. Now it's a buccolingual movement, right? The root is fixed. It's just the crown that moves. That is the in and out bends, that is called as the first order bends. Now in case they're giving you any image based question in this kind of thing, mostly it is going to be an occlusal view. So if this is the tooth, now you want to move the tooth a little, so it's the bracket. So the bend is going to be so this bend that you give here is called as the in and out bend. It is just for the buccolingual movement of the tooth. Yes, without the root movement. So this is the first order bend. Coming to the second order bend, what you need to remember here is it is a mesiodistal movement. Yes, so if that's the root, it's just going to move mesiodistally like this or like this. So most probably tipping movements. Okay, it's just going to move like this. So it is a tipping movement. So here, how does it look like? If that's the tooth, so the bend that's given here, these are second order bends. So the bend here you have to appreciate. So these bends that you give will bring about the mesiodistal movement. Coming to the third order bends. Now third order bends, what you need to remember is it is buccolingual or labiolingual. But the most important that you need to remember here is it brings about torque. Now what is torque exactly? It's just not that the crown is moving, but even the root is going to move. So if the crown is moving in a labial direction, there will be a lingual direction of the root. So this is a torquing movement. So when it comes to third order bends, you will have a profile view. So if that's the tooth, that's the bracket, it will bring about a buccolingual or a labiolingual movement. So these are the few important topics that were asked, and we've just discussed it as to how you can approach these kind of questions. And I would just try to tell you that the questions that have been appeared are just purely knowledge based, very less repeats, more conceptual, more concept based. And you need to understand one thing, you need to have a very solid foundation to answer these questions, very application based. So it's just not a very direct kind of an approach. There are very few direct questions. So how exactly can you approach these kind of the paper on the whole? Let me just give you a brief tip on this. Do your paper in rounds. Okay. So the first round that you're going to cover is going to be all the direct questions. So it's going to be like whatever you know, A is equal to B. These kind of direct forward, straightforward questions. You start ticking them. And then very easy to navigate. The paper, I mean, the way it's designed, it's pretty simple, pretty straightforward. So you will not have any difficulty navigating between questions. It's going to be very simple. So what you can do is the first round that you cover, that you take, is going to be for the very easy questions. You can just go on marking the easy questions. Some questions where you have a little doubt, where you think you know the answer, you just need a little more time, you mark it for review. So you know that you need to get back for these kind of questions. So that's the first round of questions. Take the first initial few minutes, or you can take for the entire 240 questions, you need to dedicate a particular time limit. Finish that, come for your second round. Your second round of attempt should be for those questions which require a little bit time. For example, it's an application-based question. A patient comes to you the clinic with so-and-so symptom. What kind of a treatment would you give? Or what kind of a diagnosis is it? These kind of questions which take a little more time than the normal, usual time that you take for solving an MCQ should be done in your second round. So finish your second round of 240 questions, the ones which you have marked for review. Then coming to the third round, come with the difficulty level. Now the difficulty level keeps increasing. So go for a third round and try and solve the difficult questions. If you feel you can get the answer, go for it, or keep it for the last round. Do 4 to 5 rounds. It varies from an individual to an individual. So the last round that you keep should be for the questions that you feel that you do not know at all. So don't even mark for it, for the fact that every question wrong answer is going to have 1 negative marking, and even every mark is going to like really take your ranks behind. So what you can do is the questions which you have no knowledge about, do not mark them. The ones which you feel that you can arrive at the right answer, go ahead and mark it. So this is a basic small tip that you can use for the exams to actually arrive at the right answer, to actually to give you a flow as to how exactly you need to attempt for the paper. But coming to the content part of it, coming to the entire exam on the whole, I would just say that just don't blindly solve MCQs without knowing the topic. You need to know the topic in order to be confident enough to solve the MCQ. So you should never follow a reverse pattern of studying as to no, I'm just going to follow the MCQ. I'm just going to read a little bit of here and there and just going to solve the MCQs. No, you need to have your textbooks. You need to have sufficient material with you to actually get to the MCQs. So you have 1 year in hand, and it becomes very easy for you to prepare if you follow a guideline, if you have a timeline, you know what exactly to do, what kind of material to use, what kind of way or methodology you're going to choose to prepare your exam is going to actually determine whether you're going to reach or achieve your dream seat. So I would just want to tell you that it's going to be easy. It does get easy, but the only thing is a very systematic way of approach is the main mantra of actually cracking the exam, with a lot of patience, perseverance and motivation also. And if you need any more questions that you would want me to discuss regarding the exam, you can actually send a message in the comment section, and we'll get back to you with the answers. And I would just wish you all the best in your future, and thank you.